When someone is infected, they usually have local symptoms of that infection. For example, someone who's infected with pneumonia will have fever and a cough. Someone infected with cystitis will have burning when they pee, and they pee a lot. Someone who has a cellulitis will have a red, hot, tender skin. But sometimes that infection leaves that organ and they become septic. That is to say, not necessary for the bacteria to escape the local region, it's just that there's an inflammatory response to the infection that leads to systemic inflammatory response syndrome, that is, SIRS. You can technically have SIRS from any form of inflammation. So being SIRS positive does not mean infection, but often we talk about SIRS in the setting of sepsis, that is, where there is an infection, to determine the severity of the patient's infection. What you want to take away from this lecture is identify someone who is SIRS positive and then be able to understand the severity of the sepsis. There's a few more things in there, but those are the two big takeaways. Let's start off with the SIRS criteria. The SIRS criteria is going to be based on the temperature, the white blood cell count, heart rate, and respiratory rate. A temperature greater than 38 degrees Celsius or less than 36 degrees Celsius gives you a point. White blood cell count greater than 12 or less than 4 gives you a point. The heart rate is greater than 90. It is not tachycardia, but a heart rate greater than 90 that gives you the point for SIRS. And the respiratory rate is greater than 20. Now, if you look at this list, you might say some of this makes sense, right? Well, if I'm infected, it makes sense that I'm going to have a fever and a leukocytosis. Okay, that's what whenever I see fever and leukocytosis, I think infection. You shouldn't always. You should just think inflammation because other things that are not an infection can cause inflammation. But for the most part, fever and leukocytosis make sense. But sometimes patients are really sick and they're like circling the drain about to die, so hypothermia and leukopenia also count. But then if you notice the heart rate and respiratory rate, every time you go to the gym and go for a run, you're SIRS positive. Your heart rate's greater than 90 and your respirations are greater than 20. Being SIRS positive does not mean infection. Being SIRS positive means that you, the practitioner, should have an increased suspicion of infection. The idea is this: not everyone will have a robust immune system to mount a fever and leukocytosis when infected. So as a screening tool, if ever you find someone who is SIRS positive, give consideration to an infection. If you have another explanation for the SIRS positive, okay. But always consider an infection because if you do not treat an infection, it can kill the person and kill them quickly. After we've identified someone as SIRS positive, we want to assess how bad is it. And so what you want to do is you want to look at the organs that can go into dysfunction. The most important one in the setting of sepsis is going to be the cardiovascular system. We also look at the brain, the kidney, the liver, and the lungs. The cardiovascular system could be a cardiomyopathy or troponin leak. Enzymes could be elevated, but really what we're talking about with the cardiovascular system is hypotension. And that's the one we're going to pay attention to the most in the setting of sepsis. For the brain, it's altered mental status. If they're encephalopathic and infected, they've got sepsis. And the kidney function and the LFTs are essentially going to be addressed by getting laboratory values. That is the BUN and creatinine, which will be elevated in the LFTs. We're not going to talk a whole lot about it here because ARDS has its own lecture in the pulmonary content. But if you have enough inflammation, you can cause leaky capillaries leading to ARDS, which is diagnosed on a chest X-ray showing you non-cardiogenic pulmonary edema. Check out the pulmonary videos for more information about ARDS. But these are the organs that can go wrong and what we look at when someone is septic. But then we want to parse this into the severity. How bad is the inflammatory response? Well, to be SIRS positive, you have to have 2 of the 4. 2 out of 4 SIRS positive. Not infected, just SIRS positive. To be septic, you must be SIRS positive and have a source. And that source is going to be driven by the symptoms. As we talked about earlier, you want to check the organ systems that are experiencing symptoms that might be causing the systemic inflammatory response. If they've got dysuria, urgency, and frequency, you get a urinalysis. If they've got fever and a cough, you get a chest x-ray. What often happens in the hospital is that patients are so sick, they get a lot of these tests at once. Chest x-ray, urinalysis, urine culture, blood culture. But usually what you're going to do is go after the source of the thing that is causing the symptoms. Have urgency, frequency, dysuria, get the urinalysis. If you see the red inflamed foot, you may just treat because there's not really a test for cellulitis. But if they've got altered mental status and a stiff neck, you might do a lumbar puncture. Knowing that you don't always have to do all sources all at once, usually you are directed by the patient's symptoms. The difference between severe sepsis and septic shock is really important. Severe sepsis is going to be at least one organ in dysfunction. Usually it's the blood pressure that's low, that is responsive to fluid. Whereas septic shock is one or more organs in dysfunction that is not responsive to fluid. The person with septic shock needs the ICU. The person who's not septic shock, who does not need vasopressors, can go to the floor, the wards. And one step before death is multi-organ dysfunction syndrome. That's where all the organs are failing. The person is literally reaching out of the toilet bowl to push the plunger to make sure they go the one last step. Generally, these patients do not recover from this. So it goes something like this. You're going to see somebody, you have a source because the chest x-ray or the urinalysis or something is positive, and their blood pressure is low. You give them 2-liter bolus. If their blood pressure comes up, there was severe sepsis. If their blood pressure does not come up, then there's septic shock. Septic shock need pressors, severe sepsis need no pressors. So surviving sepsis guidelines is in the process of changing, but right now we've got early goal-directed therapy. Early, because you need to intervene within 6 hours. Goal-directed, because there are certain parameters you have to meet. And therapy to keep them alive. Early goal-directed therapy. What are the goals? How do you get there? You want a central venous pressure between 10 and 12. That is to say, you have enough fluid in the tank to make sure perfusion pressure is maintained. You want a urinary output greater than or equal to 0.5 cc's per kilo per hour. This is the definition of oliguria. Again, you're perfusing the kidneys well enough so that you have good perfusion to the distal tissues. The mean arterial pressure should be kept greater than 65 millimeters of mercury. That's often done with vasopressors. And a central venous oxygen saturation greater than or equal to 70%. This means that there's nothing else going on other than the sepsis. So these are your goals. How do you get there? What's the therapy? Well, the first thing you're always going to do is fluid and antibiotics. If they are super sick and you do not know what the cause of the infection is, go broad. It is okay to do vancomycin on everybody who's super sick and de-escalate later, or narrow once you have particular culture and sensitivity. But antibiotics and fluids are critical, and you're going to give a lot of fluid. There's a little bit of debate in how much you should give. Don't give too much, 6-10 liters. Don't give too little, 500, 1 liter. When instead you want to go somewhere between 2 and 3 liters. There is no number that says I have given enough fluid for me to count them as severe sepsis versus septic shock. It's going to be more of a generalized picture. But you must also clean up the space. That is, you want to remove plastic. You want to remove the source. Foley catheters, central lines, endotracheal tubes, get rid of the plastic. But if you also happen to have a source that's stuck in a place like an abscess, it needs to be drained. And finally, if you're failing to meet these goals despite antibiotic fluid and source control, what you have to do then is use vasopressors. And we talk more about this in Septic Shock 1, 2, and 3 in the intern content. This is a very simple lecture, but it gets people tripped up all the time. Really what I want you to focus on is the SIRS criteria, memorize this, and every patient, every time, assess if they have SIRS or no SIRS. And then be able to identify the person who only has sepsis, someone who has severe sepsis, and someone in septic shock, knowing that if they have septic shock, they're going to need vasopressors. And if you think someone's infected, give them antibiotics and fluids right off the bat. And only when they get into the ICU and start having trouble do you really need to use the goals of early goal-directed therapy. What we know is the early part is what matters. Fluid and antibiotics, more so than getting to the numbers. That is SIRS.